Hello, my name is Richard Vize. Welcome to this discussion hosted by MSD on the role of integrated care systems in meeting the needs of people who are living with HIV. ICSs are now responsible for commissioning HIV services, and it's important that these services are given the appropriate priority as each area submits its 5-year strategy in the coming weeks. And this is all taking place as we reach an important milestone when more than 50% of people who are living with HIV will soon be more than 50 years old, as well as reflecting the extraordinary developments and improvements in HIV treatment. It also has important implications for how services are provided for people living with HIV. So to discuss these issues, I'm joined by 3 experts. First, Professor Jim McManus, the Executive Director of Public Health at Hertfordshire County Council and the President of the Association of Directors of Public Health. Second, Ruth Donaldson, Director of Communities at the North Central London Integrated Care Board. And finally, Cheryl Gower, the Senior Policy and Research Manager at the National AIDS Trust. So to begin with, I would like to invite each of our panellists to offer some opening remarks on the challenges and the opportunities facing integrated care boards and integrated care systems in ensuring people living with HIV age well. Jim, perhaps you'd like to start.
Okay, so I guess for me the top challenge is not turning this into something which is overly complicated or is about governance. And in my experience and in the experience of directors of public health, there are models of co-commissioning up and down the country between NHS England and directors of public health that already exist in agencies. And I think there's some learning. And the first place is to start with what's the prize, what's the value? And the value is that this population of citizens with HIV who pay their taxes are supported to have the best possible health they can right until the last moment of life. That's a very different place from where we were 20, 30 years ago. And that strategy needs to be about a largely ageing population living with HIV, as well as a younger population, and about eliminating HIV as part of the National Task Force. So we have to work together from prevention right through to care and treatment and diseases of aging for people with HIV. And you know, it's a good thing to be able to say that, actually, strange that may sound. I think the second thing is go talk to your Director of Public Health. She or he's been at this for some time. We've all got expertise in this area. I think the third thing is link it to the Women's Health Strategy. We're still not doing right by women with HIV in this country yet. We still have an awful long way to go. They're still being diagnosed too late, they're still not getting access to PrEP. I mean, all sorts of things that we haven't got right. And the system has the opportunity to do this, particularly for women and particularly for black populations. I guess the next thing that I would really love to see is proper engagement of community organisations and of people living with HIV. Now, a lot of us have thought, well, HIV is fine, you know, it's a manageable long-term condition. Most of us will have employees with HIV or friends with HIV, partners with HIV, whatever. But actually, community organisations still have a place because there's a whole load of evidence that community organisations understand sexual minorities and understand people living with HIV in ways that mainstream services still don't. And there can be a rather tribal and visceral thing of people living with HIV feeling at home in organisations that, you know, they run, they're part of. And if we're really going to crack HIV, we have to start by learning that the way we responded to monkeypox left an awful lot to be desired in this country. We didn't work with the community first. We congratulated ourselves too soon. It wasn't vaccine denial, it was vaccine frustration with people not getting it. There are lessons on what not to do from monkeypox for how to do HIV better as ICSs. So go along, talk to your DPH, talk to people living with HIV and co-produce from the start. And if you do that, you'll get a much better result. The evidence shows that's what's happened.
Lovely, thank you. Ruth?
Thank you. So my role at the ICB is really all about reducing health inequalities, commissioning inclusion health services, and also rolling out the bloodborne viruses opt-out programme.
Could you explain what that is?
The bloodborne viruses
yes.
opt-out programme. So that's a national programme whereby if you go to your local A&E and you're having a routine blood test, you will also be tested for HIV and hepatitis. And then obviously if you're identified, then there will be follow-up care provided to you. So the aim is that we identify as many people as possible. And I'd say what kind of runs through all of those programmes, and the whole reason the team was set up, is that we realised at the ICB that you need a system-wide approach to this. You need a system-wide approach to understanding those complex and vulnerable populations and improving their outcomes, but also understanding that it's cost-effective to do so. And I think that's one of the kind of biggest reasons behind this programme as well, is about the power and the importance of investing in prevention. So what runs through our health inequalities programmes is a need to empower local people. So I was really interested to hear what you were saying, how important that is to HIV, but also focus on prevention and the wider determinants. And as part of that, make sure we're collecting the right data and make sure we're measuring the right things, and really make sure that when those people that are making decisions about how we use our resource are using it in the best possible way. Because as I say, I do think this is a question about cost effectiveness as much as anything else, and we work in a system with very limited resource. So I realise I haven't quite come on to HIV yet, but I think all of those things are very relevant to HIV. I think it's really important we understand need. I think it's really important that we can demonstrate the value of investment and we can say where it's best to put our limited resource. But I see the role of the ICS as really being about bringing those experts, whether that's clinicians or people living with HIV, and making sure that influence, if you like, ripples across the system. So in an ICS that might be neighbourhood teams. So if you think about what Fuller has said about the importance of prevention and personalised care at a neighbourhood level. So it's making sure that at that neighbourhood level they have access to or have heard from experts around HIV.
And that was Claire Fuller's report,
yes.
wasn't it, into the provision of primary care services?
Yes, of general practice. But also that we're thinking about, I guess, kind of the importance of building relationships. So that's the other thing that we bring as an ICS. In all those programmes, the importance of building relationships with your local communities and understanding them and understanding why they're underserved, and that's our responsibility to address that rather than the community's responsibility. And just thinking through, I guess, about what all that means in terms of how we make sure that HIV is just like any other long-term condition and it can be treated in a systemised way. Because I guess the whole point of an ICS is to make sure that our most complex and vulnerable populations have their needs met. And I think that's got to be our priority, is both measuring that and being able to demonstrate over the next 1 to 5 years that we understand what that means and we can prove that we've done that.
Thanks very much. Cheryl?
So in 2021, National AIDS Trust did some research with older people to see the needs of people living with HIV as they age. And there were some key themes that came out of that work. The first one was about the need for more integrated care. The second was about information sharing. The third was about appropriate service provision and appropriate levels of service provision, and not just around healthcare, but also around things like social care, mental health provision, support services, things like that. And then the fourth theme that we found was that people wanted care coordination support. And it seems to us that this reform, this introduction of ICSs with their rationale of integration and being responsive to local need, is a perfect opportunity to respond to those sets of needs, particularly, for example, considering different models of care. So, for example, we could think about having shared care, new models of shared care. So that could be anything from better referral pathways where there's better communication between different providers and incorporating the person with HIV better into their care provision. But it could also be new sorts of services such as perhaps joint provision of HIV and geriatric care. So those are some examples of things that we know have worked elsewhere, and that with a sort of more integrated model that perhaps ICSs will be able to support going forward. I think there's also a real opportunity for person-centred care, and it's really fantastic to hear the colleagues on the panel talking about the inclusion of communities and people across the board, not just people living with HIV, but including people living with HIV in that decision-making and planning process. And it feels like this is a really good opportunity for some co-production and some sort of really deep engagement in service design that people can really be involved in. One of the issues, though, I think is, and I think this is going to be a big problem across the board, obviously with the NHS, is the need for resource put behind this. So, I mean, one of the things that we were talking about with the older people who are supporting our research was on the need for care coordination support. Now, at the moment, clinical nurse specialists really undertake that role sort of de facto. They're not really they're not really commissioned to do it, but they end up doing that work often. And actually, we think that there's some good evidence that introducing new roles where people are specifically designed to support care coordination, especially for people with comorbidities, which older people tend to have more comorbidities, so this is the cohort we're talking about. There's perhaps a need to introduce new roles. So some thinking around those sorts of things are our sort of key priorities at the moment.
Thank you. And it's interesting how close engagement has been identified by all three of you as absolutely central to how we get this right.